Well, good morning, everybody. It's good to see you all. Welcome to Grand Rounds. This morning we have a very special speaker with us. This is Will Kennedy, who's the Senior Medical Director for Advanced Illness at Care Oregon and House Call Providers, which, as you know, is a nonprofit home-based care organization that gives primary, palliative, and hospice care services to vulnerable populations in Portland. Will has also recently worked on a partnership with Central City Concern to build a dedicated inpatient palliative care unit for the homeless, which I'm very excited about. That is slated to open in July. He's also served as the Medical Director for Population Health Partnerships at Care Oregon. He's been the Medical Director for Hospice and Palliative Care programs at Adventist. He worked at Laguna Honda Hospital in San Francisco, which is the country's largest nursing facility for indigent populations. Will got his medical degree from Ohio University and a palliative care fellowship from Mount Carmel Health System. And today he's talking about palliative care and the safety net. Welcome, Will.
Can you guys hear me now? Is that better? Okay. Is that okay in the back? Is that okay? Okay. I talk softly, so I know that if this is not going, you guys are not going to hear me. So, is that okay? Okay, great. Are the lights going to be down at all, or is it going to be this light just because it's... Okay, great. Okay. So first of all, thank you for your time and having me here. I have no conflicts of interest to disclose. My background, as Jesse described. And there's 3 learning goals for today. One is, how do we serve our community's most vulnerable members living with advanced illness? Number 2, what partnerships do we need to provide this care? And number 3, how do we develop resilience to moral distress and burnout in providing this care as a medical community? So my story starts 20 years ago. I was walking down the street in Boston. I was there for a geriatrics rotation as a 4th-year medical student. And for a brief period of time in my life, I was into black and white photography. And so I happened to have a camera with me with black and white film in it. And I was just walking down the street, lost in my thoughts, and I turned and saw this man. And it stopped me completely. I mean, I literally just stopped and looked at him, and because he was looking down, I didn't feel that I was in any way imposing on him and just in taking the moment in. And as you can see, his face is in his hands. There's no sign asking for food or for money. And despite doing palliative care for 16 or 17 years since then, I've never seen anything that was more of a moment of singular despair than that experience. And so much so that I took a photo and framed it, and it was up on my wall in my apartment when I was a resident, and it's been up in our palliative care office for many years as a reminder of the types of experiences those that we're trying to provide better care for experience on a daily basis. And I had 2 questions at that moment, right? Almost feelings, I would say. One of them is, how does this story end? How does someone taking this in with this degree of problems in life, knowing that they're going to get sicker and the difficult lives that they have, how does that in any way end well? And the second question I had is, how could I make a difference in this? Because at the moment I felt, even then, a deep ambivalence that I cared and wanted to do something, but I was also entirely paralyzed by having absolutely no idea how to engage a situation like this. So I lived with that when I went through my residency and my palliative care fellowship and did what you might say is just typical hospice and palliative care medicine, typically serving older, frail populations and so forth. But about 10 years later, I read this quote by Bill Gates. And this was, I think, the first experience I had in unpacking what that moment meant. And this was Bill Gates reflecting on his transition from being the full-time CEO of Microsoft to the full-time philanthropic world, and specifically addressing global health problems. So he says, and he's giving a commencement speech at Harvard. All of us here in this yard at one time or another have seen human tragedies that have broken our hearts, and yet we did nothing. Not because we didn't care, but because we didn't know what to do. If we had known how to help, we would have acted. The barrier to change is not too little caring. It is too much complexity. And that was the first time I thought that represented how I felt at that moment. This situation was just too complex for how I felt as a human being to help him, or certainly in the ways that I'd been trained. That this was much beyond that. So around this time that I read the quote, I took a job at Laguna Hospital, like Jesse said. And Laguna Hospital, if you don't know it, is a unique institution in the United States. It is on top of a magnificent hill in San Francisco. It's been there for over 100 years, and it has historically always served indigent populations. And because it is San Francisco and there is so much diversity there, there's an incredible amount of specialization on these different floors. And so each floor, they're open wings, open floors the whole way. So you're not going from individual room to individual room in this hospital. You walk in and you look all the way down and see just beds all the way there. And because so many of the people that are admitted into the hospital don't have safe discharge plans, their lives are very complex, they'll often stay for decades and living there, and that becomes their community. And in going there, I arrived right like 3 months before the Great Recession hit. So I arrived to start a palliative care program, and they said, surprise, your program's been eliminated by the city. So they offered me a secondary job, which was working nights as an internist. Right, so we have some internists in the room, and you know what that means, right? So that was definitely not what I was anticipating. But what it did do for me, though, was give me a great advantage to spend a different type of experience with the patients than I was used to, right? It had been doing lots and lots of productivity kind of work in terms of palliative care up until this point. And you might know the story from Victoria's Suite, God's Hotel, and she talks about the amazing stories of the people that have lived there and what a unique practice environment this is. And the great gift of this experience was, since I was no longer expected to be building this program, it was much more moment-to-moment my experience. I'd show up at 6 or 7 at night for the beginning of a shift. As you know, when you're moonlighting and working nights, things don't start getting really active until later in the evening, typically. The nurses change shifts and all these orders come up and all these other things. So I would just go and hang out at the bottom floor of Laguna Honda where they had a hospice. And because it was San Francisco and very temperate, the inside hospice, which was also an open wing, which was pretty amazing to see all of these people in beds that were in some stages of end of life, yet all together. But it opened up into this garden space, this beautiful garden space where the patients would come out. And so most nights, for the first couple of hours, it would be typically 3 of us hanging out in the garden together. It would be myself, a patient who was still ambulatory, and then a volunteer from the Zen Hospice Project. And the Zen Hospice Project is relevant because so much of that volunteer training program is around being with patients, and that's what we did. We just hung out and talked about life. And as you can see here, this is a picture from the garden, and I remember just like I had that photo with the gentleman on the street in Boston and not knowing what it meant. I would look at this each night and see, what can you see there? You see the engravings on the tree, essentially like tattoos. You see the mementos on the ground. You see the painting on the wall, all by patients, right? And I remember taking that in, having worked in other inpatient hospice settings before, freestanding buildings, where there was nothing like this, right? And feeling like this is just something very different, but I didn't know how to contextualize it. So after leaving San Francisco, and this is just a few of the mementos on the ground of talking about people's lives that had lived and died there. And like I said, many of these people had lived at Laguna for a lot of their lives, right? And it truly was their family. So this end-of-life experience for them was very significant for the entire community there. So I'm there at Laguna Honda, and I'm having this experience that I'd never had before in terms of the nature of these individuals' lives and the complexity of their lives. And one of the main questions I had, Laguna has 780 beds. Is this 780 beds that is just a unique station, so to speak, in the midst of what is everything that we would consider to be normal healthcare? Or is this representing something bigger? And I wasn't sure about that. And this was the first time I think that I really understood this. And this is from the California Healthcare Foundation. 30% of all Californians are in the safety net population, right? And that was the first clue to me, of which has been the last 10 years of learning, that what I saw at Laguna was not exceptional, right? And that this is indeed how people live and live the end of their lives. And so by the safety net, this is the Institute of Medicine. What do we mean by that? The providers that organize and deliver a significant level of health care and other related services to the uninsured, Medicaid, and other vulnerable populations, right? And we all do that here. In every hospital, there's a component to this. So I was working, as Jesse said, I was the medical director at Adventist for their hospice and palliative care program here in town. And right when I started there, Care Oregon had come over and said, we'd love to do a contract and have you take care of our palliative care, provide palliative care for our patients, the members we serve. Care Oregon is the state's largest safety net health plan, so a different patient population, although I didn't understand that then. And what I found was, it was like I was living in two different worlds. Here I was doing hospice care, taking care of the people that I had been trained to take care of, that were familiar to me, older, caregiving surrounding them, et cetera, frailty. And then it was like I was going into a different world where the patients were much younger, much more complex with behavioral health problems, so substance use disorder, severe persistent mental illness oftentimes, and then the overlay of social determinant risks like housing and food insecurity. So, and I can tell you that I went from feeling in one space where I felt comfortable and competent to another space where I felt very uncomfortable and ineffective and incompetent. And after doing this for a number of years and partnering with Care Oregon and trying to understand this, I ended up coming to Care Oregon full-time to work on this job, to work on this problem as a learning journey, really. And so in coming to Care Oregon, it was really this understanding of this was an entire world that I was not really that aware of in terms of the types of problems and the lives that people live and how to care for people that have really complex problems. And so what is it that we see, that we experience, including in this room, when people have these problems? What's our experience as providers for them? They're younger in age typically, right? So an Oregonian who has severe persistent mental illness or is chronically homeless dies 20 years younger than someone who does not have those problems, right? So the patients that I was taking care of in the palliative care program were often in their 50s. In fact, 50s was the biggest demographic in the group, right? So a very different set of life problems at that point. The mental illness that I had talked about, history of substance use disorder, lack of social supports. If someone is living with chronic homelessness, oftentimes because there's mental illness or substance use disorders, what happens along the way in those lives? Those people have typically burned their bridges with their friends and family who've tried to help them, but it hasn't worked out. So when they reach end of life, people are typically alone. Food insecurity, housing. Housing is an easy one to think about, and that is if the best laid medical plans do not work if someone is about to lose their house, right? There's very much a Maslowian dynamic to this. And that if you're not solving the bottom part of the pyramid of Maslow's hierarchy of needs, is that all the high-tech medical work or best laid care plans don't matter. Lower health literacy, and safety. By safety it means for people that have lived traumatized lives, that are disenfranchised, how do you create a care environment that makes them feel safe? Because oftentimes what they're reacting to is that sense of not feeling that way. Lower health literacy, particularly relevant in advanced illness because the essentialness of creating effective goals of care so that people receive the care that they want and don't receive the care that they don't want. But in these situations, that's often impaired. So that's our experience. But what is it the experience for someone who is living this experience? And this is just a summary of a list created by Sister Adele O'Sullivan, who is a palliative care nun in Phoenix and who has worked in palliative care and end of life there amongst the homeless for many years. And so she separated it from her experience into two main categories, the system barriers and the cultural barriers. And so you can see the system barriers, and again, this is just a summary of a longer list. No insurance, complicated eligibility requirements, disorganized services, inaccessible service locations, no documents, no transportation, complex health problems, fragmented treated silos. You're going here for your heart failure, you're going here for your neurologic disease, et cetera. If you don't have a car and you have all these other problems staying organized, that's incredibly challenging. And then what about the cultural barriers? Provider attitudes, discrimination, cultural incompetence, prior bad experiences, distrust of the system, language, illiteracy, and disorganized lifestyle. And the example I give of this, the nature of these problems is in one of my first years at Care Oregon, I was in a cubicle actually with all the case managers. And I kept hearing a problem come up that didn't make sense to me. And the problem was the person had no identification. And if I lose my wallet today, what would I do? Well, let's see. I would drive home or have my wife come and pick me up and drive home, go get my birth certificate, go to the DMV, get a driver's license, and it would be like nothing happened. But for these people who had many of the problems I described there, along with living with advanced illness, is not only did they not have any ID, they didn't have any birth certificate, they didn't have anyone to support them or vouch for them. So imagine the degree of depersonalization where you cannot even prove who you are in the face of all these problems. that was a light bulb moment for me to the entirely different world that this was a lived experience for so many people. So what is underneath so many of these lives where we feel it as complexity, whether it's us as providers, where we feel it that even our best laid plans are blocked, or we see all of those different cultural and system barriers, is that so oftentimes it's the history of traumatic experience, especially traumatic childhood experience. This is a burgeoning area of research with the CDC and applying at all types of different environments, whether it's school systems, the criminal justice system, but in healthcare this is a big area as well, right? And the idea is poverty, physical abuse, sexual abuse as a child, some manner of those insults creates altered neurologic development, especially around emotional regulation and executive function, which then leads to the adoption of higher risk behaviors to cope with the symptoms that are associated with those problems, right? PTSD, anxiety, depression, etc. The adoption of those high risk coping behaviors, especially smoking, leads to the early onset of chronic illness and earlier death, just like we talked about, which is that people that have chronic homelessness in Oregon or have severe persistent mental illness die decades younger, right? And when I first came to Kerrigan and I was looking at the populations and the types of problems they had, the thing that stood out to me was the amount of lung disease, of chronic lung disease. And this was underneath it, is that people were smoking to deal with these incredibly stressful lives, and then the early onset of lung disease, right? So traumatic life experience is in no way isolated to the populations I just described. This is an article from the New York Times talking about the incidence of PTSD in people that are in the ICU. So 5 million people go through the ICU in the United States each year. Up to 35% of them have PTSD in the following years. And that does not include the ICU nurses and family members who are also traumatized by these experiences, right? So this is a growing area of research and the consequences of how we deliver healthcare. And then finally, this is by the psychiatrist, the book, The Trauma of Everyday Life by the psychiatrist Mark Epstein, talking about that trauma is really a part of our life, right? Trauma that means that it fractures our sense of self, fractures our sense of our relationship to life. The one thing I always think about is in taking care of patients that are very old, the signature experience of anybody that's lived to be 100 years old is the number of traumas they've had in their life, the number of losses, right? It's just a product of how long you live and of some luck mixed in. And here's what Dr. Epstein says. Trauma is not just the result of major disasters. It does not happen only to some people. An undercurrent of trauma runs through ordinary life, right? But in the patients that we serve, their lives are so much more severe in these types of problems, and the ability to care for them is impaired by these histories. So this is a model of the traditional palliative care 3 pillars, right? So if you're providing palliative care, effective palliative care, and when I say palliative care, I don't mean strictly somebody that's wearing a hat saying I'm a palliative care provider. I mean good medical care, right, of which palliative care is a part. Symptom management, and I would add in there, symptom management is not just the treatment of physical symptoms, but also the treatment of psychic symptoms, right? Depression, anxiety, loneliness. Care coordination, obvious, and then goals of care, right? What does somebody want? How do we make that happen? What's important to them? But I can tell you in our work and working with these populations is that there is something that is actually more fundamental than these pillars. And it's how we've built our programs out. Is that in the middle of there is a therapeutic relationship. With so many people we serve, they are truly alone. And in the absence of having a longitudinal, trusting therapeutic relationship in their life, so much of this work is not possible, right? And if you think about it, that is so much of what all of our lives are, right? Is that the meaning that we have in our lives, the healing that we have that's the potential of our lives is relational, right? It's the other people in our lives that matter. But if someone's alone, it's just such an impairment into having any kind of progress or having effective care. So we've done outpatient palliative care at Care Oregon, of which I've been either on the part of providing that care or have been on the part of working at the systems level since 2010. And if you asked me, what would be the biggest lesson I've learned from that? It would be that point, right? Is that it's the relationship that matters the most. That the ability to care for somebody, hold that space of uncertainty, and walk with them. But I'd never seen any research. That would just be my anecdotal experience. But then last summer at Stanford and the VA, the Veterans Administration in Palo Alto, they set up a study that I think provides compelling evidence that this is indeed true. And so what they did is they took veterans, VA patients, so have a higher degree of complexity than your average person, with stage 3, stage 4 cancer, and they did one intervention. They paired them with a specially trained lay health worker, so like a community health worker who'd been trained to help create a bond with them, a trusting longitudinal relationships. The intervention was 6 months, and focused on helping them identify their values and goals and then implementing that, having it documented, having their care teams known what they wanted. So, and it's a randomized control trial. And when I read this study, palliative care studies tend to almost always work. I mean, there's exceptions, but it tends to be that medical care is so aggressive typically that any type of intervention has a positive outcome. But what struck me about this, beyond the fact that it directly addressed what is that hypothesis that we had from doing this work, was the effect size. So here it is, one intervention, a non-licensed person walking with these patients for 6 months, and here are the outcomes. Hospice use twice as much. Documented goals in the chart 5 times as much. In the last month of life, a 95% reduction in going to the hospital and emergency department. Think about that for a second. I've read palliative care studies for 15 years, and I tell you this is one of the most remarkable studies I've read, right? And because it makes you think, are we even doing this work in ways that's most appropriate for these populations? So this is, if you Google palliative care and an image on a computer, you'll get 50 different flavors of this schematic, right? And it's just what we would think about is you're diagnosed with some life-limiting illness, you receive curative, life-prolonging care, and then along the way you're receiving palliative care, supportive care. And the idea is you would receive both of them at the time of diagnosis, but then as the curative care becomes less effective and the palliative care becomes more important, and then at some point you can see those the two colors merge at the top, and there's a magical moment where somebody says, I would like hospice. And what is hospice? Purely focused on quality of life, right? The end of curative care and the beginning of a different set of goals. And then finally at the end, where the gray box ends, someone dies, there's a death, and there are bereavement services provided for the person's surviving loved ones. And for context, in the Medicare CMS benefit, bereavement services is a requirement, right? So this is standard of care, you would say, for typical hospice care in the United States. So with that in mind, I want to show you an outcomes study from our internal data at Care Oregon for our palliative care patients. So this was done at the end of 2016. And you can see a pie chart there, and this is just asking a simple question. And by the way, when I asked this question, I didn't have an answer in mind. It was just a curiosity. Was when somebody comes into our outpatient palliative care program, what happens to them? Where does that end, right? So there aren't a lot of options, right? You could die, you could go into hospice, you could be discharged for a variety of reasons. And then there's this strange bucket, the 21% in the upper left corner, which is like things like people move out of the area, lose insurance. It's kind of like it's a nothing bucket. But if you see this, does anything stand out to you? Especially in relation to the schematic I just showed you. I'm sorry, what's that again? Right, a high percentage are dying in palliative care and hospice. And so that's exactly what I thought when I looked at this. I said, oh my gosh, right? Our patients, and by the way, this would be consistent with what I thought, but still to see it in a pie chart like this is powerful. Our patients they're not going to hospice, right? They're staying in the palliative care program, right? Half. That's not how the program's designed, right? That's not how we think about this conceptually, right? So why is that? So there's a number of reasons, but one of the most important reasons is that idea of relationships, is that our palliative care team has walked with these patients. They are oftentimes the only trusting relationships in their life. And even though hospice provides 5 times more benefits in terms of the type of clinical care, is that relationship is primary. Right? So this is a problem in the model, right? Is that hospice may not be appropriate at all for these folks. They may never want to go there. They're 50 years old, 55 years old. They don't want to leave their trusting relationships. Maybe they have more confused or ambivalent goals of care. There's a lot of factors there. And then the second piece is bereavement services, right? So we're investing in caring for those that have the loved ones of those who have died, which is a beautiful thing, right? But what about people that don't have any loved ones, right? So we'll get to that point, but the point is that in this model, from a social equity perspective, from a social justice perspective, being able to provide care in a parallel way, not a sequential way, is a key priority in our work, right? That we can't force people to make choices to join hospice or to make a change which may not be aligned with their life experience or goals. But that's how the system is set up. And so it puts people who are the most disadvantaged in situations that feel the most internal conflict for them at the times when they need care the most. And the second one is our patients are younger, right? Much younger. And I remember having this conversation, talking to a geriatrician about this, and I was like, our patients are so young, but yet when you look at the data, they're frail, they have all these medical problems. She said, oh, Will, I mean, like in a knowing, kind of like, I should have known this, she said, geriatrics is not an age, it's a condition. And so in many ways, what we're doing is providing geriatric-type care for a population that doesn't consider themselves geriatric, and we don't consider themselves geriatric oftentimes. I wasn't, right? And we think about that frailty, cognitive impairment, caregiving gaps, all of those things. So going back to that point of bereavement services, right? If someone doesn't have a loved one and we're investing in bereavement services, how do we think about supporting someone in that sense for someone who doesn't have one else, right? And it made me think about this picture again. And what human need is being expressed by all the patients that went through Laguna Honda's hospice to put their names on the tree, for the mementos, to paint, to create all of those things, right? It's its own form of legacy building. But there's the knowledge there that there is no one to carry on their legacy because they don't have any loved ones. And so their legacy is alive in the present moment with those that are caring for them, their community, people that are the caregivers, the healthcare providers, but also they're creating a sense of permanence in this way, right? So I was up in Ottawa a couple of years ago, and Ottawa provides, I would say, the most in-depth and has the longest history of serving these kind of populations, especially the homeless, at end of life of anywhere in North America and maybe the world. And so I went up there to just see it firsthand. So this is the Ottawa Mission. It's been there since 1906. They've done that. They've served Ottawa's most neediest citizens for over 100 years. And if you look, you can't see it here, but to the right there, if you go around the corner, there's a new building, and it's 21 beds of just providing end-of-life care for the homeless. Okay? And so I was talking to their executive director who had founded the program, the end-of-life program. She'd been there for 20 years. And I was telling her about the garden at Laguna Honda and everything I saw in the mementos and all the different visual things and how much of an impression that had made on me. And she smiled at me. She said, oh, well, that's, she said, we have the same issue here, and so we do plaques on the wall for all the people. She said, this is because people want to know that their lives mattered and that they want that to be shown, right? And so that's the answer. And of course, this is not in any way something unique to these disenfranchised populations we serve. This is a deeply human need. And so this is from Werner Herzog's documentary, The Cave of Forgotten Dreams. And in The Cave of Forgotten Dreams, you have to go way into the cave with a torch 30,000 years ago to create these paintings. There was a deep need for the people that did this. And he talks about it specifically, somebody put their own hand on the wall, put dry red pigment in their mouth, and blew it around their hand to create this. And he talks about this statement of saying, I was here, right? This is the deepest human need. And then here is a South African proverb, same idea. A person is a person because of other people, right? This idea that our lives have so much meaning because they're relational, right? It's our community with other people. So why is this so important now? We talked about I had this original experience in which I felt ineffective and moral distress, and then it seemed like this is a bigger population issue. But this is continuing that to the moment of now. And that is 30% of all Americans are uninsured or on Medicaid. There's a lack of structures in place. This population is aging just like any other population, right? The baby boomers, the disenfranchised, the homeless of the baby boomers are getting older. But remember, their onset of disease and geriatric type conditions is happening decades earlier. So a 65-year-old baby boomer who is has these problems has a much higher degree of medical problems typically. America's essential hospitals, which is another way of saying of America's safety net hospitals, operate on a 0% margin. The average margin for a non-safety net hospital is 6%. Huge difference, right? There's very little data to describe how to do care in this population. I remember when I first got into this, first of all, I looked in all the literature, there's nothing there. And then I started calling, I would just do this kind of, I'd hear a rumor and I'd call somewhere and call around the country. And there's so few people, about a year or two later, it got confused and they thought that I knew how to do this work. And so they'd call me for advice, even though that I was out there calling them, right? But that speaks to it. Are we at an inflection point as a population? Like I said, the aging of the baby boomers. Older minority Americans will increase by 160% compared to 59% for non-Hispanic whites in coming years. In suburban low-income area neighborhoods, the percentage of decedents receiving hospice care was less than 5%. Right? The opioid epidemic is also a palliative care opioid access issue. Right? Even as we're doing these population-level things, I can tell you people call me all the time trying to get involved in Kerrigan's pharmacy system to get a very appropriate opioid approved. Right? So there's a blast effect or an inadvertent consequence from trying to treat the opioid epidemic. Oftentimes people that are in Medicaid, this is a well-known fact, that are in these populations, they don't have the same access to non-opioid pain therapies that other people do for chronic pain, for example. Right? So there's a lot of moving parts in this. So this is from Paul Farmer, the great Harvard public health crusader, and his work in Haiti and around the world. He's saying, for me, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. Right? And I believe from the last almost 9 years of experience of doing this work is that we can provide effective palliative care and end-of-life care for the populations who are complex and seem to thwart us in providing them care. So this is a patient in our palliative care program. This is Cynthia. And Cynthia was born in Fort Wayne, Indiana, and was an independent spirit, moved to California when she was 21. She has two great loves in life. One are animals, all kinds of animals, and art. She's a master gilder by training. And she was in California and then followed her love up to Oregon, where she raised horses for 14 years in Corbett. And during that time, she reached the natural age of needing a colon cancer screening test, like a colonoscopy. Scheduled it, everything was just completely normal. And by no fault of her own, a week before she was meant to have the screening test, she lost her insurance. Okay? And so as you know, for many people in these situations, there is no easy way to re-up with insurance and so forth. She went back to living her life. Fast forward however many years, she was admitted to the hospital for ongoing symptoms and was diagnosed with very serious colon cancer. Okay? In short order, she needed food, she needed housing from a series of consequences from this, and had all kinds of medical problems. Right? So she was admitted into the Oregon Health Plan, ended up at Kerrigan, ended up in our palliative care program, all right, to help her work through a really complex set of problems. And this is her shortly after she received supportive housing. She was told it would take 7 years to receive supportive housing, going through the normal channels. As something I learned at Kerrigan, there's a whole back-end sophistication to helping advocate for people and find housing, and she had found housing within a couple of months through one of our case managers, and this is her talking about this. And I can tell you, the nurse taking care of her, I was looking for someone to really tell their story of their experience and why this work is so important. And Cynthia insisted that her story be told. It got rescheduled, I had some conflict, and then she wasn't feeling well one day. And I basically said, you don't have to do this, right? But she insisted. And so I went out to her house, and I think I asked 3 questions in 90 minutes. She just spoke the entire time, right? So if you go by the Heathman Hotel, some of her work is in there, right? And unfortunately, I tried to do the audio because she talks about this, but the audio wouldn't work. So, but this is what she wanted to say, among other things. She wanted to know just how important it is to us, and by us, she means all of the people that we've described, that are some way at a disadvantage. I'm sure some of us as patients are not able to show our appreciation to verbalize it, so I'll say it for them. Don't stop, right? She was incredibly articulate of all the things that had happened to her and how difficult her life was to manage this on her own. Transportation, not showing up for chemotherapy. I mean, it's just amazing to hear all this in one shot, right? But again, seeing her in that picture is that it is possible, right? And then my favorite moment in the 90 minutes is she talks about how loved she feels by those of us caring for her. And the nurse, I was sitting there talking to her on the couch, and her nurse was 5 feet away, and they both looked at each other and told them they loved each other during the moment. Yeah. So the second part of this is we can care for these people, but it's very hard to do it when you are a provider who's burned out, right? And by provider, I don't mean just physicians. I mean any of the healthcare disciplines. And it struck me as how oftentimes, and including myself, and this is certainly my journey, is here I was taking care of older, frail hospice patients, like I said in the beginning, and it felt comfortable and reasonable and all of those things. And then here I was taking care of these other patients where I would end up sitting up in the middle of the night drinking tea, working through the whole case in my head because I had so much moral distress of what didn't I do, right? Setting up the plans, the person loses their housing, and it's just a terrible experience. And I'm thinking, should I be doing this work? What have I done wrong? All of those things. So moral distress as a cause of burnout is very real, right? So this was a study of, I think, 18,000 physicians. And like I said, physicians, because I think the data is most robust, is what we're talking about, but I think you could extrapolate to any of the licensed healthcare disciplines. So these were the burnout rates that people reported. 42% overall, internal medicine, my discipline, 46%, family medicine, 47%. I always ask as a trivia question, what was the least burned out? Or one of the top three. I'll take one of the top three. What was that? Orthopods. Okay. Anything else? Yes, right. So there's dermatology, plastic surgery, and what was the other one? I think it was pathology. You know, my favorite answer was, I was doing this talk, and somebody guessed radiology, and somebody said, no, those guys sit in a dark room by themselves all day. That's depressing. You know, and it was so anyway, the point is, as people report this, high prevalence, when people report that they feel very burned out, the studies now are showing, because health systems are realizing the cost to replace a burned out physician is very high, the consequences. I was just at a talk yesterday, and at this speaker's academic institution, they had quantified it to replace a burned out nurse, $100,000, to replace a burned out physician, $150,000, right? So how about burnout in people that provide palliative care? Does anyone want to guess that? Zero? We have a zero. It's not Price is Right. You can do whatever you want. Yeah. So, anything? 62%. Right. Even more distressing about this is, for every board-certified palliative care doctor in the United States, there's a need of 4 or 5. 10,000 people join Medicare per day. There's like 100 fellowship spots. And I think 50% of all palliative care physicians expect to retire in the next 5 years. So this area of providing advanced illness care for people is a moral and healthcare crisis, right? So how do you create resilience for providers, as healthcare providers, right? 2 different types of coping mechanisms, ways to build resilience. There's the personal, meditation, exercise, high-quality relationships outside of work. The second piece are system factors, right? Not staring at an EHR for 80% of your day, right? Some of these different issues. But the point I want to talk about is, in caring for these populations, there are certain strategies that will build our capacity to care for the people that need our care the most, but often cause us the most distress, right? And this is by Tony Bach, who is a professor of medicine at the University of Washington, also a palliative care physician, and an expert on burnout. And these are just some points that he says when he talks about how do we think about building systems of care. You prototype and you iterate. You don't sink all your resources into doing things one way. And I can tell you in our populations what that means is, if somebody keeps coming to the hospital for the same reasons, then you have to do something different, right? But oftentimes that's not how the system works, because it's so fragmented that we don't see necessarily what the root cause is and how something might be different. When I first started working at Kerrigan, I was amazed to hear the story of somebody coming in with very serious heart failure who was homeless and discharged back to the homeless shelter with a bag of medicines, right? I know that the people in the hospital had done everything they could, that there was so much complexity there. But you could also look at this story and say, how is that going to end up? It's going to end up right back in the hospital, right? These are very difficult situations. So you have to build bridges. We need a multi-stakeholder approach. And when we're dealing with populations who have serious medical illness, but they also have behavioral health complexity and social determinant complexity, it is by definition a social service as well as medical intervention that creates the outcomes we want. Right? So I want to tell two stories, two different projects that I'm involved in around this. Does anyone know who this is? Yeah, so this is Dr. Bennett, who retired in 2014. She was a primary care provider in our community for her whole career. And in the early 1990s, she realized that there were a population of people who are homebound in every community, but vulnerable and homebound in Portland, and they need care brought to them. So she literally started a practice, House Call Providers, at her kitchen table. She worked for the first 3 years without making any salary. It was purely mission-driven, and it grew from there as an idea in terms of what can be done. And I've talked to her about this a number of times, is that it is amazing what one person, what their belief and commitment over time can accomplish. Bill Gates says, we often overestimate what we can do in 1 year, but we underestimate what we can do in 10 years. Right? And so Bennett's story is a perfect example of that. So her practice, House Call Providers, started at her kitchen table, like I said, grew into what is now, oh gosh, last time I checked our census, it was 1,700 or 1,800 patients in the Tri-County Portland area, right? Doing primary care, palliative care, and hospice. This was done, these are just some numbers from 2015. I think there's 20 primary care providers in the practice now, all going into the community, right? All going to where the care is needed. So they've done, this is, just in 2015, over the years, from starting at her kitchen table, 135,000 visits to vulnerable Portland residents. You can see there's all kinds of, serving all types of vulnerable populations. And 2 years ago, after a long-term partnership, Care Oregon and House Call Providers merged together. And one of the main reasons was that Care Oregon wanted to ensure that House Call Providers would continue to serve the most vulnerable patients, the most vulnerable of its members in our community, right? My picture's up there if you can do a Where's Waldo. So that's one example of a partnership where, as we have invested in this model and we've built out population-specific capacities. So we now provide primary care, palliative care, and hospice. We go into hotels, we do homeless work, we do all these places where it's very difficult, right? Is that by investing in these populations and investing in the capacity of our workforce, we can do care that has historically been extremely difficult to do. So the second body of work is what will be called the Blackburn Center. And this will be the country's first built from the ground up inpatient unit to provide palliative care in the homeless. So this is on 122nd and Burnside. It will be 6 floors in total. All of the hospitals, all the health systems in our community, combined with Care Oregon and Central City Concern, $21.6 million to build this facility, right? So a true community effort. Going back to that idea that it's a multi-stakeholder approach to solve complex problems. But if you look at the 6 floors, you can't see the top floor there, but it's the bottom 2 floors will be a full capacity, federally qualified health center. Just like Old Town Clinic, if you know Old Town, run by Central City. So in other words, not just primary care for the homeless, which is what their work is, but also very strong behavioral health. I don't even know what code gray means anymore. I only know there's So the clinic will provide full spectrum services for the most needy, the homeless. Why would you build this on 122nd and Burnside in our community on the east side? Because poverty is migrating east in Portland, right? So this is about building structures where it's needed most. There'll be a MAX line there, you can see, there's a bus line. So on like I said, the first 2 floors is the medical clinic, but then on the 3rd floor will be the 10 palliative care beds, right? To provide care for people who die on the street. They die in the hospital because there's nowhere else for them to go. That's not what they want to be, right? Ottawa, like I showed you the picture, has done this for 20 years. They started with 8 beds, now they're at 21 in full capacity, right? 2 months ago, even before I did, or after I did these slides, the University of Pennsylvania came out with a landmark study showing that in the next 11 years, so a short time by population health standards, 104,000 people will approach end of life while being homeless in the United States. So I remember when we first started the ideas behind this model, I remember thinking, will anybody show up? How important is this? And now, just over the course of 3 or 4 years since we've been working on this, is that now, very likely, every community is going to be thinking about some type of solutions from this because it's going to be such a social problem for them. Right? So if you want to go fast, go alone. If you want to go far, go together. Another African proverb. And the point is to make these services work, house call providers providing primary care, palliative care, and hospice for our community, to provide at the Blackburn Center end-of-life care, palliative care for the homeless in an inpatient setting. It requires all of us to do this work. That's the one thing I am convinced about more than ever, is that it will never work by one person or one organization owning this. This has to be thought of as a community set of problems and a community set of solutions, and it is possible. So this is Bill Gates ending that commencement speech talking about how to resolve complexity and align it with our caring. But humanity's greatest advances are not in its discoveries, but in how those discoveries are applied to reduce inequity, whether through democracy, strong public education, quality healthcare, or broad economic opportunity. Reducing inequity is the highest human achievement. So I invite you to join these efforts in any way you can as part of our healthcare community to help serve the people that need these services the most. Thank you.
Questions?
Yeah?
Well, I was going to say, one of the things that seems to be, to me, to be a problem is the transition to hospice is often sort of a disruptive transition. Your data from Care Oregon shows that. The same thing is true in practice. Maybe people lose their home health nurse or they lose their physician. What's to be done about that?
Yeah, the question is, hospice creates, I would say, not aligned patient requirements, right? It requires you to transition from only comfort-based care versus aggressive care, and oftentimes people want some mixture of both of those along the way. It requires you sometimes to give up relationships that are most primary to you. And so this has been a long-term problem, and I think that's going to change over time, what's called hospice carve-in. In other words, Medicare Advantage plans are all of a sudden going to own the risk for their hospice services, which I think are going to mix this up a lot. And as healthcare becomes more integrated amongst health plans and health systems, is that I think these different silos are going to break down some. So that in other words, that people won't be forced to make those decisions that are not aligned with what they want as a patient. And there are examples of that in the United States. So I think it's happening, but it'll be slow, right? So in other words, and the example I gave here would be, why shouldn't the people in that palliative care program get as many services as those that are in hospice and not be forced into those situations? Right? Yeah?
A couple, 3 years ago, we had a talk here, I think by Dr. Sweet.
Uh-huh.
And that was pretty cool. Can you give us a kind of a little quick summary of what happened? How did that go from the old slow care hospital up to what it is now? We're not up to speed on the last 4 or 5 years.
So what he's talking about is that the original Spanish-style Laguna Honda Hospital, which had been there since I think the late 1800s, it was from the late 1800s, is that it was not seismically sound. Surprise, surprise, right? So it was on top of a big hill in San Francisco, and so they actually passed a levy and built a new Laguna Honda Hospital next to it. So a big modern hospital. And so with that, I still have a colleague who still works there. My understanding, I've been in through the new Laguna, it doesn't have any of the things we would think about as that original specialness in terms of the hospice isn't there on the bottom floor anymore, the rooms are individual, all of those things. But they still serve the same population. I mean, I think the spirit of the work is the same, but it's for good and some bad, it's in a modern healthcare facility. Does that answer the question? Okay. Yeah.
Well, over 35 years of being a primary care internist, one can see that the former model, which was almost purely relational, has switched pretty dramatically to transactional. And the concept that we need resilience of the individual physicians to provide relational care seems to be flawed, because I don't think it's the doctor's fault. I think it's the system's fault. And, I mean, I applaud you for working with the systems, but what we see is that, in order to continue to provide relational service, you kind of have to go concierge, because there's no other way in the systems to do this. So I thought I'd get your comment.
I wouldn't disagree with any of that. I mean, I think that what is going to change, though, is that as things like, and I'll use health plan terms here, right, but it's like things as value and risk and accountable care organization ideas become more and more predominant in the way healthcare is designed, is that relational becomes effective, right? And it gets away from that very fragmented view of productivity, which, I mean, I think gets at many of the problems you probably experienced in the course of your career, right? So I am optimistic about that in some ways. I think also the ability to provide care for people that have advanced illness has to be in that way. It just does. It just does, right? So hope that answers that. Yeah. Yeah. Wow. So the question was, how much for the social determinant risk or responsibility should physicians be responsible for versus the government? I would have to say, first of all, I hadn't thought about it in those exact terms. I think that, right. I'm not sure this is going to answer the question exactly that way. I would say, first of all, adding more to physicians is not going to solve the problem, in my opinion, right? I mean, that's not the end point of this. To me, the best answer to what you've described, and I'm not sure it's the physician versus government dynamic, but it's the idea is that, and there was a book written on this, is that in Northern European countries, they spend about twice as much on social services as the United States and about half as much on medical care. I mean, it's called a ratio, and maybe I should build that into the presentation. But I think there's some element to that, is that a lot of the problems of poverty are medicalized, and that is not an effective way to deal with this problem, right? And so it ends up in these strange places like Kerrigan, or I shouldn't say strange, but they end up in places that may not be fully aligned, and that we need to wrap around the people we serve, and including the physicians, with more comprehensive models. I'm not sure if that's the right answer, or a good answer, but I certainly think that as we move into the space of advanced illness, is that interdisciplinary care is the standard. A physician cannot manage this, right? There's just too many other elements that goes on in a practice, I think. So, yeah, any other questions? Yeah, yeah.
Just a comment. I am appalled at the epidemic of burnout among physicians. 62%, I think. If it was a disease in our patients, we would do something about it. I read a very sad statistic that the number of health administrators has increased 5 to 10-fold in the last 10 years compared to the number of physicians as the cost of healthcare has increased. We are turning not into healers, but into typists, into electronic medical records. I just read last night an account of a 94-year-old lady brought to the emergency room where the physician had to stop typing information about her to ask her if she had domestic violence, because there was, what I just learned, is a hard stop in electronic medical records. All that information goes very badly, and it reminds me of the Me Too movement. I think that we need to say stop, and we need to take back medicine into our hands and learn how to say we're not going to take it anymore.
Yeah, I've seen that graph where it's like the rise of non-physicians and medical administration positions is like this, and physicians is, I'm not going to, that's such a big topic, but the one thing I'll say just as an interesting observation of mine is the happiest healthcare providers I've seen in the city, and my job is like going around and visiting all kinds of people, is at Central City Concern, right? Central City Concern, or one of the happiest, is that they work with homeless populations, they work with the patients that would be considered the most complex and most problematic in most settings, but because it's such a strong sense of community and collegiality amongst the mission and the providers, as well as the patients, there is something deeply powerful and human about that. And it doesn't answer all these questions, but there is a truth in that, I think. Yeah. Yeah. Uh-huh.
And over the last year, I've been employing many more palliative care, principles in my practice. And I would have to say that I have gained so much more satisfaction, and I feel less burned out. I feel it's so much better. I have such a better relationship with my patients. But it takes time. It's like jumping on a treadmill. When you do goals of care talks with your patients, when you get to know them, when you try to understand their values, when you actually shut your mouth and let them talk. And that doesn't, jive with how we're supposed to run our practice. We're supposed to be at the height of efficiency, do, 5 problems in 20-minute visits, especially, we're supposed to be rolling out palliative care into the primary care setting.
Right.
I mean, that's the goal. Across the country, it seems that's the goal in nonprofits medical group. And yet, financially, it doesn't pencil out. I mean, I don't know if this is actually true, but somebody told me that the at-home program at Kaiser just collapsed last week because it doesn't pencil out. Our elder at home program here at Providence is being, reorganized because it doesn't pencil out. And whenever you have a geriatric related population, it's not penciling out. You can put a TAVR on a 100-year-old and make that profitable. But if you provide this kind of care, which is so needed, and it's very rewarding, but it doesn't pencil out. Programs are being shut down across the country. I'm listening to you. It's a lovely talk. Thank you very much. But I looked at your building and I thought, oh my gosh, where's the money coming from? I mean, because, how do we support this work, across the country when it does not pencil out?
I first of all, thank you. Those are all true, right? I mean, those are the realities we live in many ways. But I would say is that I'm more bullish than that long term. I mean, in other words, that I think that as the system changes around things like I'd said, risk and value and payment and all those things, and goes away from that kind of very narrow view of fee-for-service, which the world is still a fee-for-service world, right? Even though it's talked about that, is that those things do become more valuable. I would have said, if you would have stood me up here 4 years ago, I would have said there's zero chance that the Blackburn Center is being built. I mean, I remember the original conversation I had with now the CEO of Central City Concern, and we were just like, boy, wouldn't that be unbelievable? And so, I mean, there's a part of me that thinks that every amazing thing in society started with a few people thinking about this could change. And I agree, these are huge problems. I'm not trying to in any way minimize that. But it does feel like there are positive and there are this social, and that's what this talk is about really in some ways, right? And at the heart of it for me was thinking, if getting back to what the distress that you experience and see is, if you can build models of care to care for the people that we feel are the most complex, then that becomes the center of which less complex populations and other needs are met. That's the idea. There is an idea behind this, but yeah. Yeah.
Is there any model in the world that you would recommend emulating as quote-unquote ideal?
You mean healthcare systems?
Well, palliative care assistance for disadvantaged people.
Oh gosh. I'm going to punt on that. I mean, I have ideas, but I'm not in any way. Those are just, just opinions. Yeah. Yeah.
Do you have any recommendations for the fastest way to expedite people into the system? Because in dealing with the 60% Medicaid population where I work,
Uh-huh.
often just getting through Care Oregon and through the administrative piece that's the biggest obstacle to care or getting them connected to social services. Even though Care Oregon is better than many of the private insurers in that way, that's the biggest obstacle I run into and we run into in my practice. So do you have any ideas?
There's a whole, there's the care coordination part of Care Oregon, which facilitates that. And I'll just, that's still the best way that I know of. And then to provide some of the services we talked about here is House Call Providers, which is a sister organization of Care Oregon. So there's that relationship. But I would also point out something philosophical to that, which is kind of related to these questions around how do you think about these as a population or as a community, which is Kerrigan is a medical insurance company, right? I mean, there's something about that framing that even points out how there's just, right? Does that make sense? You know, that it's, the system is so fragmented, and it's really hard to, they're not a housing, for example, they're not a housing organization, but many people come to Kerrigan to try to find housing because they found that to be the most expeditious route, right? I mean, there's just something about all this that I feel like, gosh.
The average wait time is 1 to 2 years to get
Yeah.
into housing without being expedited or extreme medical
Yeah,
care. So
yeah.
when you have a patient you're trying to manage
I-
that way,
You know, my first introduction to that reality was there's a housing case manager at Kerrigan, and he knows all the landlords in town. And the way he gets brokers things is saying, like, my word of mouth is, I know this person, he coaches the person that's going to receive housing. I was like, oh no, this is just so, this is our system? You know, so it's hard. You can always call me, and I'll try to help you. On my business card, it says, on the back of my business card, it says, like, for any questions, call me, because it's like, it's a big black box, and, you know, I just try to find people, but, yeah.
Thank you, Dr. Kennedy.
Yeah, thank you so much. Thanks.